Thank you very much, Professor Cano, and welcome everyone to this symposium. And really my job actually today is to really set the table for the next two speakers. So I'm going to be going through an overview. I'm sorry, I'm going to be covering a lot of material quickly, so I hope I don't challenge the translator too severely. But in any event, we will cover, I think, a topic that I think is very relevant to us in this current day of imaging. So these are my relevant disclosures. We've had, fortunately, an access to a lot of different instruments, including the TOPCon devices we'll be talking about in this discussion of swept source technology. So I want to start first with just an overview about swept source OCT. I know many of you are already familiar, but it's always worth talking about where we've come with regards to this technology. And a reminder to all of you that swept source OCT is another Fourier domain OCT technology. So, in the past we were interchangeably using the terms Fourier domain and spectral domain, but we probably shouldn't, because spectral domain and swept source are both Fourier domain technology. So, in any event, the advantages of swept source, and Nitin Chaudhary will really talk a lot about the advantages of swept source versus spectral domain OCT in geography, but just in general, the advantage of swept source OCT is, yes, it's faster than spectral domain OCT, but the advantage that I want to really emphasize through the course of this presentation is the better sensitivity that it features, and I'll give some illustrations to explain that. So again, the difference in terms of the instrumentation, both types of devices, spectral domain and swept source, encode the depth information in the frequency space, but how do you get the frequency information? With spectral domain, you get it with a broadband light source and the spectrometer to get the frequency information. With a swept source system, you use a tunable dye laser, so you don't need a spectrometer, so you're able to get this information in frequency space, and so you acquire, for example, an A-scan that looks like this, but then you have to apply a fast Fourier transform to turn it into the type of A-scan we're used to seeing. So in any event, what about the sensitivity advantage? So I want to show this illustration from a nice spectral domain OCT device, and this is actually a B-scan of my eye. And this is the vitreous, the zero delay line has been oriented to the vitreous. And as you know, with spectral domain or swept source systems, you have to set one direction of where the sensitivity is optimal. And so look at the external limiting membrane, which of course is this very fine structure that you can see there in my eye. And as you move the scan, as your photographer changes the focus to move the scan away from the point of maximum sensitivity, you can see that it gets harder and harder to see the external limiting membrane. I mean, maybe you can pick it out still, but it's pretty difficult to see. And that is a very nice illustration of this type of sensitivity drop. And so again, the key advantage with swept source OCT is that yes, there's some drop in sensitivity, but you can see with depth, the drop in sensitivity is much less. And that really has very important implications, I think, for imaging compared to spectral domain OCT. And maybe it's easier to see side by side as you move away from the zero delay line what happens to the sensitivity of the images with spectral domain versus swept source. So again, in terms of the technologies that we have that are capable of both anterior and posterior segment imaging in the swept source realm, we're really talking about the TOPCon devices, so that's what we're talking about today. And again, as I said, when you have this type of lack of sensitivity loss with depth, it really aids you in your visualization of the outer retinal structures and the choroid. And one of the topics that's been of great interest recently in the research space is studying the internal structures of pigment epithelial detachments. And you can see a lot of detail. Many of us look when we treat PEDs, we try to eliminate the fluid, but not necessarily the neovascular tissue. And if you want to do that type of treatment strategy, then you really need to have fine imaging of the internal structure of pigment epithelial detachments. Now, there are some swept source systems, especially if you're imaging a patient who has relatively few optical aberrations, you can actually image with extensive averaging and even start to see the outer segment mosaic. Almost without AO imaging, you can start to see this, which is pretty spectacular. And of course, another big advantage of swept source is you can scan at very high speed, so you can scan very large areas in a rapid fashion, and there are research devices that actually operate in millions of A-scans per second, so-called megahertz OCT, and at that point you can scan very large areas and you can get essentially OCT images that very much look like our traditional fundus images. The big difference though is these OCT images, we can acquire them from any where we can present them from any layer of interest. So it's not just like a typical fundus image, which is a summation. You can actually get the image from different layers and different structures. And again, this en face strategy for looking at OCT data, I strongly believe, is the future of how we'll be looking at our OCT images. In any event, acquiring big field images, yes, of course you can do this with spectral domain systems. It just happens to be easier to do with swept source devices. And of course you get beautiful imaging of the deep parts of the eye. Look at how deep you can get into the lamina curvosa. Our glaucoma faculty, as it turns out, is very interested in studying laminar anatomy and how its implications for glaucoma that we're now able to do with some ease with swept source technology. So this is an example of a patient. Again, anybody can show great quality individual B scans, but I like to look at my volume scans. I'm not sure how many of the audience traditionally look at all of their B scans, but getting good quality volume scans is pretty important. So this is an example of a patient. Let me go back here, excuse me. Sorry, this is a patient, of course, who has, I think it's pretty apparent, an abnormality involving the optic nerve, as well as you'll see the fluid in the macula. But actually, when you see the fluorescent angiogram, it even highlights the optic nerve abnormality. But it was really nicely illustrated. You saw on the swept source OCT scan. And I thought, just for ease of illustration, we'll take one of the B scans. And you can see this patient obviously has a pit maculopathy. But look how you can see all the way to the base of the pit. You actually can image the remnants of the lamina at the base of the pit, which again, I'm mainly showing this case to illustrate the power of the technology for deep imaging in our clinical experience at least. So this is just another patient where we've had a patient with hypotony maculopathy. You see the choroidal folds. Again, it was nice to get these large cubes. Again, getting a big B scan, not a big problem. Getting dense cubes that really facilitate getting good quality en face images. I think that's the advantage that we have. Also, another case to, let me see, can you click in this movie for me somehow? It's not playing automatically. But what I really want to illustrate in this movie was the fact that the image quality in the anterior retina. Are you able, can you start the movie, please? You just have to click down here someplace. So in any event, I want to illustrate the fact that, thank you, that the image quality, even in this really deep staphyloma in this patient, is pretty similar in the anterior and posterior aspects of the retina, which we found to be especially helpful, as I said, for en face images. Another patient with the AION, you'll see actually this patient has a fairly prominent thickening of the optic nerve, but you actually can see the subretinal fluid that's accumulated in this patient, even at the base of the optic nerve. Again, this en face way of looking at images, I think, is really going to be the future of how we look at our OCT data. I'm getting used to now looking at my patients with these kinds of en face movies, which I think are really facilitated by the dense scanning protocols that we use now in clinical practice. So I thought I'd share another anecdote of a case that I think really hits home the advantages of looking at our OCT data and an en face strategy. This is a 51-year-old patient, came in with an acute onset scotoma, had a history of migraines. The referring ophthalmologist thought the examination was normal. I think it's pretty clear that it's not normal. I think you can see, especially on the red free, that there's something abnormal there. So what is it? I mean, maybe many of you already know, it's just the autofluorescence image highlighting that. There's no leakage on the fluorescent angiogram on this patient in that area. But what you can certainly see on the OCT imaging, you'll see it even on the B scans as they're going by, that there is an abnormality of the internuclear layer that you can see right there. It's abnormally bright. But I tell you, it's a lot easier to see and understand the distribution of the abnormalities when you look at it in the en face mode. You'll see that patch appear there. And I'll take one slab right from that internuclear layer for illustration. And you'll see that abnormality is, again, this is an en face slab obtained at the level of the internuclear layer. You can see there's this patch of hyperreflectivity that's present there. And this, of course, what's the diagnosis? Pretty obvious. This patient has paracentral acute middle maculopathy, in this case associated with migraine, which is unusual, but has been described. Again, we talked about the advantages of sensitivity, but I want to highlight from a clinical device perspective, we are fortunate these swept source devices do operate with a longer wavelength. And just as a reminder, I mean, we're talking about operating at the 1 micron regime or 1050 nanometers in this case, and contrast that to our usual spectral domain devices that operate, unless there's some research systems that operate in green, but most of them operate at 840 or so. And so again, why is that? For posterior segment imaging, you have to get your light through a lot of water in the vitreous. So you're really confined by the absorption spectrum of water. So of course, imaging in the visible portion of the spectrum, pretty easy. But there is a relative dip here at 1050 nanometers that allows us to actually image the posterior segment using OCT, hence why we have that. And again, being able to image deep structures, imaging choroidal melanomas and the like has been facilitated by this approach, for example, and this is just the B-scan movie of that same case. But I'm not going to say too much about that because David Pelaez is going to give a very nice presentation about that coming up and really talk about this important application of swept-source OCT, but of course, being able to do volumetric imaging of the choroid may be relevant for many diseases, including patients with central serous who can have massively dilated choroidal vessels. But there are other applications as well. One of the things that we find particularly helpful is in imaging patients with geographic atrophy, and oftentimes to get the geographic atrophy image, we'll take a slab image at the level of the choroid. But actually, with swept-source OCT, because of the deep penetration, you actually get even better contrast when you take the slab at the sclera. Actually, this is an example of outlining the area of atrophy on a scleral slab assessment in a patient with GA. But it's not just for imaging the choroid and deeper structures. Keep in mind that the benefits and sensitivity can appear elsewhere as well, and we can get great vitreous imaging with these devices. And there's a lot of interest now from the FDA level as well as from a variety of other groups looking at new endpoints for uveitis based on imaging and quantifying cell and OCT. So I would stay tuned for that because that work is in progress, even at a regulatory level. So in any event, I will say that this type of enhanced vitreous imaging is something. I don't really think you need to really enhance it much because you see the vitreous quite well with these devices. But that's also a new mode that the devices feature. And showed Dr. Kishi in Japan had done some very nice work where he studied the evolution of PVD very nicely using an Atlantis OCT device. But I didn't want you to leave today thinking that this is just for the posterior segment. Obviously, I'm a retina specialist, so my talk is heavy on the retina. But as I said, our anterior segment colleagues have been very interested in OCT, and especially with new therapies that are targeting the angle or have or devices or materials that may reside in the angle. Studying the angle has become very important now, and so traditionally we've done this with time domain, long wavelength devices, but more recently we've switched to using spectral domain devices for many of the trials in the reading center. But you can see there is a challenge at 840 nanometers for visualizing the angle recess, and that's something where swept source devices really shine, but more than the swept source, the fact that they're long wavelength at 1050, you're able to actually get into the angle recess, and in fact you actually can get through the sclera quite well. You can actually image the pars plana quite nicely and consistently, we found in patients using swept source OCT. And there are also opportunities to look at other structures. In the dry eye space for clinical trials, there's a lot of interest in doing volumetric imaging of the tear meniscus and the tear film. Here you can see the tear film or the tear meniscus, the tear lake, quite nicely illustrated on the image. Here's just another image, again showing you the beautiful quality that you get. Look at the angle recess. It's spectacular how well you can see the recess, in fact. But in any event, here you can actually see the particulate matter in the tear film. So that may actually have implications for our dry eye patients as well. So that's another potentially exciting future clinical application. And our glaucoma colleagues have been imaging their filtering blebs, and you can see the cystic spaces, and you actually get a pretty good depth of penetration with this image that was captured on the Triton. Okay, so I'm going to switch gears and finish up with swept source OCT angiography. And OCT angiography is the huge rage. I think there's another instructional course I was told following this symposium as well. But in any event, I just want to start out with a definition. What do we mean by OCT angiography? We're referring to the isolation or extraction of the microvascular circulation from the OCT image data using a combination of specialized image acquisition as well as processing techniques that don't involve the use of an invasive dye. So that's sort of the basic definition. So in terms of how you approach the problem, all of the techniques are based on, so far at least, are based on developing a motion contrast. So you can imagine if you're able to eliminate Brownian motion and bulk motion or patient eye movement, what else is moving in the eye? Primarily, that's the blood flow in the retinal blood vessels, and so that's really what you're trying to get. And how do you get the contrast to actually detect motion in the eye? One, you can look for the phase shift that's produced by moving structures, or you can look for a magnitude variation. And you can think of this as, as blood cells come in and out of a particular voxel in the OCT image, there can be a change in the intensity of the reflection at that location. So if you're scanning the same location very fast over time and you're looking for differences in the brightness between the images, then you might be able to extract something that's moving. And that's one approach to motion contrast. And again, you can do this with spectral domain or swept source systems. Nathan Chaudhary in the next talk is going to be talking specifically about some of the advantages that he's seen in his clinical practice with doing this with a swept source approach. You can sort of guess some potential advantages based on what I've already said about swept source OCT with regards to its deeper penetration and potentially better visualization of deeper vascular structures. But what are the advantages? Why has there been so much press? And I'll tell you, at the upcoming ARVO, we're going to have 2 paper sessions on OCT angiography alone, and as well as a symposium and the like, and it's just gone crazy, right? So what are the advantages of OCT over conventional angiography? Well, it's obviously non-invasive and no dye. It's rapid, and you can do it on your existing OCT platforms. And what does this translate to? It means you can do it frequently, which means it's very useful for longitudinal assessments and for incorporation into clinical trials. Also gives us better vascular detail. One of the structures that we never saw before with conventional angiography was the radial peripapillary capillary network. And so that may have some relevance to optic neuropathies and glaucoma. In addition, it's depth resolved, meaning that you can see multiple capillary layers in the retina. And of course, what's really exciting for all of us as clinicians is the prospect of automated quantitative data. Okay, so again, to understand OCT angiography, and there'll be so many courses, I'm sure, at Academy next year as well on interpreting OCT angiography, and believe me, we need it because it's complicated. But you need to know what normal is, and of course, this is just going through, you can see where the slab is obtained, but as you slab through the retina, you can see that the appearance of the capillary plexus does change over time, its morphology as well as its dimensions can be quite different. Here's just 2 of those slabs just for your interest. And you can see the difference in the size of the foveal vascular zone, as well as, again, even the morphology of the capillary network and the orientation. There seem to be some interesting differences. The only caution and caveat is, what you see here obviously depends on how you chose your boundary lines. And as you'll see, there's a lot of differences and variance, even amongst devices, as to how this is done, which is a real problem. So one of the approaches in the reading center, because the DRCRNet in the US is already incorporating OCT angiography into trials, and so how do we deal with this segmentation and then segmentation problems in the setting of disease? One approach to sort of try to hope that we are not fooling ourselves is that we look at these things with these types of en face movies. Again, I've been stressing this en face approach to looking at OCT data. With OCT angiography, it's really risen to front and center, but looking at it through this type of movie-based approach, I think, is going to have real legs going forward in the future. So again, I apologize for boring you with some things that are maybe of only interest to reading center people, but to understand what the data means in the setting of disease, you need to know that it's reliable and reproducible. So we've done a lot of studies now following subjects over time and acquiring images in different settings to see how does it change. What are the limits of repeatability? And so that seems actually pretty promising. The great thing about OCT angiography, of course, is that there's such contrast for seeing the vessels that it makes quantification relatively straightforward. So skeletonizing the vessels and then doing a variety of different metrics, I think is relatively easy. There are some challenges, though. One of the things I highlighted was maybe it might be interesting to measure the foveal vascular zone. But when you're trying to compare normal to disease, it's a big problem when there's a big variation in normal. I mean, these are all normal subjects, and you can see the FAZ size is quite different. So how can you understand what is truly pathologic when there's such normal variation? How can you adjust for this? Well, One approach may be that you might be able to make a correction based on the morphology of the pit on the reflectance OCT. This was a nice study that was done that showed there is a relationship between the volume of the pit and the area of the FAZ. Unfortunately, you can see here there's a relationship, but there's a lot of scatter as well. So it's not a perfect solution, but it may be one way to handle this. Now, the other challenge, though, is there even a single FAZ measurement? I've already highlighted the difference in the FAZ superficially and deep. And in fact, we've published on this and measuring the FAZ at different depths, in fact. And again, this is just showing that same thing from that paper, showing the difference in the size of the FAZ. Fortunately, this is a very consistent observation regardless of device. We actually demonstrated in that paper that there's a difference in terms of the FAZ the area and the diameter between the superficial and deep. And this is sort of a summary of all the papers in the literature that have looked at FAZ size. Our results are pretty much in the same range. But again, the real interest, though, is how can we take this normal information, apply it to the setting of disease. This is an illustration of a patient with non-proliferative diabetic retinopathy. And you can see that there are some significant vascular alterations, including aneurysmal changes. And I don't have all of the data included in this presentation, but there have been nice papers that have shown that you don't see all of the microaneurysms that you see on a fluorescein angiogram, on an OCT angiogram. Part of that relates to the likely slow flow that's occurring in these aneurysms. But one of the things that we have seen, and we're not the first to describe this, several groups have, is that the vascular alterations, particularly the microaneurysms, seem to be more prominent in the deeper layer compared to the superficial layer. So we didn't really understand that before with fluorescein angiography, but we are in a position to understand that now with the depth resolved capability of OCT angiography. And again, despite the overlap or the huge amount of variability in normals, we were able to, this is a study that we recently did, just looking at patients with moderate to severe non-proliferative diabetic retinopathy, we found that the FAZ, in fact, was significantly enlarged compared to patients who were age-matched normals. Not shocking, but it's something that you can measure still. But FAZ measurements are probably only one of many metrics that we will use to study and evaluate our OCT angiography data. Another important one, I think, will be capillary density. And in that same paper, we also looked at capillary densities in different rings around the foveolar vascular zone. It's not so important, the ring dimensions that we used. But just to make the point that, in fact, we were able to see in normals, for example, that the inner ring, there was more difference between the superficial and deeper layer. But by the time you got to the outer ring, the capillary density was actually pretty similar in the superficial and deep retina in normals. And so we contrasted this to our cohort of patients with diabetes. And again, we're able to show and demonstrate using this approach a significant reduction in the capillary density in patients with more advanced diabetic retinopathy. And again, this is the kind of thing that the DRCRnet is interested in. Do these things have implications for outcomes for patients? Obviously, you'd imagine if you had really severe capillary dropout, you'd expect the patient's going to have a poor prognosis. But perhaps finer gradations, we can find useful information. But we don't know yet. The reality is that this is still being studied. This is a patient who presented with a single cotton wool spot. We're not sure why, actually. But just to show that the superficial and the deep capillary plexus in this patient, you can see there really seems to be a significant defect. And I have to say that I'm not sure if this patient, I suspect that the perfusion is probably reduced there, but you can also see that there is a drop in signal. Now, there seems to be very low signal on the angiographic image compared to the standard reflectance image, but there's still some probable loss of sensitivity. You're not entirely sure, but this kind of comparison where you look at the drop in sensitivity in the reflectance image relative to the OCT angiography image, B-scan, can maybe sometimes be helpful as you try to ascertain, is this an artifact? Is that actually true capillary dropout, which we suspect there is true dropout in this particular individual. Let me show you another illustration. This is a patient who came in complaining of blurring of vision in both eyes over the last year or so, relatively young individual. And you can see that this is the B scan, and you can see pretty easily, you can probably already know what the diagnosis is. You saw it go by on the en-face image. It's much quicker to look at that, by the way. But you can see these cavitary lesions in the retina. Probably everyone here knows the diagnosis for this patient. This is, let me just go forward here, sorry. This is the color image, and you can see that there is a little bit of a grayish haze here, maybe even a venule that's doing something funny there. And of course, you saw the cavitary lesions in the retina. But notice that when we did the OCT angiographic image on this patient, yes, the superficial capillary plexus looked a little bit abnormal, but what was really striking was when we dropped even below the deep plexus down towards towards the outer nuclear layer, we were still seeing these vessels, and they're sort of these dilated abnormal vessels. And of course, we didn't see anything down at the photoreceptor level except the cavitations, and nor did we see an abnormality at the choriocapillaris capillaris level in this patient. So again, what's the diagnosis? Well, the fluorescein angiogram was probably not necessary. That's one of the conditions where we probably aren't needing fluorescein angiography anymore, because we really can make the diagnosis quite well with OCT angiography. This, of course, this patient has MACTEL type 2, fairly typical presentation, confirmed by OCT angiography. And there are a variety of different retinal vascular disease applications. MACTEL and diabetic retinopathy are a couple, and Carl Glittenberg has done a lot of these nice sort of 3D renderings. Rick Spade is someone who's really touted as we think about how do we visualize our OCT angiography data in a way that we can understand clinically. Volume rendering may actually play a role. We always thought volume rendering was kind of a gimmick, in our management of patients. Maybe for vitreoretinal interface disorders it was useful, but for OCT angiography it may have real legs. I mean, these are the kinds of things we're trying to think about in the reading center. How can we deal with different artifacts, and how can we understand what's going on? So I think Rick may be correct, in fact. There's another illustration of a patient from Carl with a branch retinal vein occlusion with non-perfusion that you can see there. And with this type of nice volume rendering approach. Maybe not so useful in this particular case, but I think Nathan is going to show you some nice choroidal nevascularization cases where I think there's some real potential value in this approach. So that's a good segue to talk about choroidal vascular disease, and this will be sort of the last topic that I'll cover. So again, OCT angiography is really kind of, you'll see so many papers coming out on looking at choroidal nevascularization, like this patient who has a pretty, beautiful, actually, you can see on this web source image, how beautifully you can see the laminar structure within the fibrovascular pigment epithelial attachment all the way out to Bruch's membrane here. But when we do the OCT angiogram on this patient, and Carl helped us with some of the processing, you really can get a really nice contrast for identifying the choroidal nevascular membrane. It's actually quite impressive. And some things to point out, I mean, it does seem that the density of vessels is reduced more centrally compared to peripherally. It's what we'd predict based on what we know from anatomy and also our experience. The vessels mature in the center, the more active vessels are at the periphery of the membrane, so that's actually kind of nice. But what was neat was this patient came back a few months later complaining of some vision loss, and now you can see there's an additional abnormality in the subretinal space of this patient. There's also a little bit of hemorrhage associated with this. So what's going on? Well, this is what we saw now in the OCT angiogram. Not only did we see this large complex present in the sub-RPE space, but now we saw this additional vascular abnormality which corresponded to this. So this patient actually had a type 1 membrane that ruptured through the RPE and developed an additional type 2 component. It's easier to compare there between these two visits. So there's some very nice changes that you can detect and follow over time using the OCT angiography. There are various patterns that you can see. This is a patient who had sort of like a chronic membrane, was starting to develop some atrophy, and you can see the large vessels corresponding to this portion of it under the sort of the residual RPE space here. People have already started to come up with some very interesting names. Some people have called this a dead tree and things of that sort. Unfortunately, we're going to have a Macular Society pre-meeting this year where we're going to try to actually get to a consensus classification, so we start using the same terms. But what's interesting is this patient developed some additional subretinal hyperreflective material here. What is it? Is that just exudation? Is that fibrin? No, actually it's a nice new net that developed adjacent to the dead tree in this particular case. Another entity that's gotten a lot of interest now are these patients who don't have any exudation but have suspicious looking PEDs. And now we're recognizing that a lot of these patients have choroidal neovascularization. Phil Rosenfeld has suggested this term intermediate neovascular AMD for these cases. There's some uncertainty as to how to best manage these patients. Because we were never treating these patients before. And should we be treating some of them? Maybe. We'll see. Okay, and then these are a couple more cases. These are a couple of cases from Carl, just to illustrate different patterns of nets. I included this one mainly because Carl thought maybe he could see even a polyp in this case. I don't know if that's actually a polyp. Most of us have thought that the flow is too slow in polyps to really visualize them using our current OCT angiography methods, but that's something that's an area of hot study and interest right now. We've been very interested in quantitative analysis of these membranes because you get such great contrast. It's pretty easy to extract the net, actually, as you're seeing from these cases. And so you can easily compute an area of the lesion. And then you can actually look to see how much of the lesion is actually composed of vessels themselves. And so you can compute that. And of course, then you can use that to compute very simply a vessel density. There are a whole host of other metrics. I don't have time to go into the kinds of things that we're looking at. But these are some that people have proposed to use in choroidal neovascularization trials moving forward, like this case from colleague David Sraff, who has looked at the change in these lesions over time. And of course, they've been suggested already as endpoints for use in trials, and there's some ISTs that have started that have been doing that type of thing, in fact. And of course, there may be new endpoints for initiating treatment. We talked about these intermediate neovascular AMD cases. Do you treat such a patient? No fluid, but just this membrane. Don't know yet. And then, of course, there are already those among us who are using this to guide retreatment. Again, we don't have all the data, so I'm worried about using this to guide retreatment. So some people are saying, well, if I treat a patient and then the membrane disappears, if it comes back on OCT angiography, even if there's no fluid, maybe I should treat them with anti-VEGF therapy, or maybe I shouldn't extend them if I'm doing treat and extend. I don't know if that's the right thing. We don't know, but that's the kind of thing that we all obviously need to carefully study. And of course, there may be prognostic implications. Again, I've replaced dead tree with disciform here, but the implication is that there may be a variety of different phenotypes that we see on OCT angiography that may tell us something about what is going to happen with this membrane. So lastly, I'll mention just briefly about geographic atrophy because it's an area of great personal interest for me. And obviously, when you have the RPE lost, it's very easy to see the deeper choroidal structures. And of course, you can still see the normal choroidocapillaris here. But that's not the part that's interesting. The interesting part is what's happening here. You can see that there seems to be some attenuation of the choriocapillaris at the margin of the lesion, and that's kind of a hot area as we think about new ways of defining atrophy, so stay tuned for that. I don't want to leave this talk without making it seem that OCT angiography is some perfect technology because it's far from that. There's still a long ways to go, I think. Processing algorithms are still evolving. As I mentioned, we're still lacking all of the supportive clinical trial data, but that's coming. That problem, I think, is going to be solved. You do need to have efficient tracking systems, and the nice thing with the Triton device that we've been using is it has a great tracker, and it really eliminates the motion artifact, the patient movement artifact, but still you can have projection artifact from motion created by overlying vessels, and Nathan's going to talk a lot about that as well, and that's actually a real challenge in interpreting these OCT angiographic images. And of course, we already talked about how interpretation depends on accurate segmentation, and we don't learn anything about leakage as of yet. That might change. Johannes de Boer's done some nice work that's suggestive, but we'll have to see. So in any event, I'll close with this last slide. Really, hopefully I've been able to convey some of the potential value of swept source OCT and OCT angiography. I think it's really enhanced our evaluation of deep retinal pathology, the choroid, the vitreous, and the anterior segment. I think en face is the way to go for the future, and this ability to really see the circulation non-invasively in a depth-resolved fashion, I think, is very useful, and really, I think, has further expanded the role of OCT in managing our patients. Thank you very much.